There you go. Thanks, Tito. All right, so next. Okay. All right, this is not a good idea, is it? I feel I've got imposter syndrome, all right? I'm sure Wai Kyong did as well. And I'm sure probably those of you working in the NHS, this is probably also just something which makes you just sit there and go, oh dear, what's he going to say next? I thought I knew about computers and I want to start plugging all my computers and my smart ideas into your big network. So I guess what this talk is a bit different to, I think, the other bits and pieces on your program today, is that if you like, this is the user's story. Okay, so I'm sort of downstream of the entire thing. I'm not the clinical end user who's using the EPIC system, so this is at UCLH again, or whatever system, is I'm kind of like that in-between person, the person you've got the health warning about, who wants to come and play with the computers in the hospital, okay? And that's probably a fairly bad idea. But I think there are probably some areas where we could agree it's helpful to have some clinical input in some questions. And if we can do these things collaboratively, then we think we can make some big progress. Now, this is obviously in the context of kind of like modern hype about big data. So this is, if you like, the original big data. Anybody know what this metric comes from? 455 exabytes. Anybody know what an exabyte is? Yeah, it's 18 zeros. Okay, it's not a sort of, anyway. So that's the amount of data, if you like, encoded in 1 gram of DNA. So that's my biology link back for you and so on. And so obviously big data is this sort of thing. And this is kind of where I work. I work on the intensive care unit. Those are the machines that go ping. We've got ventilators. We gather measurements off those up to sort of 150, 300 odd hertz. We've got drug pumps. We've got dialysis machines and bedside monitors. We've got clinical notes. We've got drug recordings, and we've got the rest of it and so on. And we think that actually there's probably some useful information in that. There is a paradigm in medicine that the only way to learn about the world is to go into a randomized controlled trial. But there's a problem with that, isn't it? These are expensive, slow pieces of science that once you've started that particular supertanker will give you one particular answer. And actually, we just don't have the time, the money, the resources, or the energy to use that as our go-to tool. We need to be able to learn from the routinely collected clinical data that's around us all. So these are your standard 4 V's of big data. I don't really need to go over that with you guys, but I think this is the key thing, and this is really what this is all about, is that the reason that we all get stuck is actually that, and especially in the healthcare space, is getting that data to people to do something with it is an enormous challenge. And it's a challenge which normally means we actually can't do very much. And it feels like we've been held back in the NHS for an incredibly long time. We've been able to learn from the things that are around us and actually try and do things a bit better for our patients. So this is the EPIC story, okay? We went from a hospital, which is kind of right down at the bottom in terms of sort of digital maturity. And we were going through this big bang piece, okay? And if you read the EPIC sales pitch and the sales slides, they're also going to tell you that the right side, the analytical maturity is going to change at the same sort of way. And I think there's some truth in that, but it's an incomplete truth. In that actually at the end of the process, what you're left with a fantastic clinical tool. You're left with a really high quality reporting database, but you're not really left with the tools that you need to be able to interact with those things. And why is that? Well, it's because the where I really sort of started, isn't it, is you don't want doctors messing around with operational systems. That we need in all of the stuff that we do to be hugely respectful of patient privacy and the data that we have the opportunity to work with. That generally, where you do something good, it becomes very bespoke and very local, which means we can't really collaborate and work, we can't put things together. And the standard toolkit in the NHS is the Excel spreadsheet, okay? And if you're super lucky and you pay 50 quid at UCH, you can get an Access database as well, all right? But that doesn't really feel like the tooling for 2019, does it? It doesn't really feel where we want to be. This is the system architecture before EPIC go live, okay? And I think this is really just to make the point. This is why I'm not allowed to touch things. And there are genuine use cases where people get given database access and they write, and I normally have to ask people if they know SQL, but I'm just going to say this: select star from patient, okay? Right, okay, you guys get the joke. All right, this is the privacy stuff, isn't it? I mean, like, I just updated this last night and so on. I mean, this week, we've got to get this right, okay? There's a resource here we have to learn from these data that are around. I mean, it's almost like some sort of duty that we have, okay? But we're going to mess it up massively if we don't do this incredibly well and incredibly right. This piece, okay, everywhere you go, it's a different system. These things can't talk to each other, and you just get locked and you get stuck. And anything that you do, which is a great idea, suddenly then becomes incredibly expensive to deploy and learn somewhere else. And also, you know, I have to go on an EPIC training course, and I move hospital, I have to go on a Cerner training course. All of these things just take time, and it stops us working together. This is my sort of biggest frustration. Okay, so I work here at UCH. ICU's on the 3rd floor of the tower in there. Across the road, we've got UCL, okay? Every university's got its boasts, okay? But UCL, God, okay. UCL likes to boast that it's got the leading computer science department in the country, okay? So whether it's the leading or not, it's a pretty good one, and it's certainly a big one. This across here is HDR UK, Health Data Research UK, and it's also the Institute for Health Informatics, okay? Down here, we've got the Alan Turing Institute, and actually in the Welcome building here, we've got the headquarters of HDR UK. How many people do you think I see from any of those organisations inside the hospital? I mean, they're all called health data. Alan Turing's got part of its charter, improving health. It's a bit absurd, isn't it? It's just a road that we have to cross, but it doesn't happen. And how many people from the hospital go across the road the other way? They have 50 MSc students a year in the Department of Health Informatics. How many of them do projects on actual NHS data? None. It's impossible. It's really hard, and we have to fix this. It's just going to get in the way. And this is really what it's like inside the hospital, okay? Wai-Kyung has told you exactly the same story. This is human computing, okay? It's Jung, she's a research nurse. She's got years of experience, both clinical and now running sort of clinical trials in the hospital. And with all that experience, she spends about 4 hours a day. These are just 2 separate applications. This is our old clinical information system. This is a case report form for a clinical trial. She's typing. She's a human computer cable. Okay, this is just utterly absurd. Is it all going to get better? So this is sort of the epic story. It's all going to get better. So this is a little spreadsheet I borrowed from University Medical Center in Amsterdam, and a physician out there was looking at antibiotic dosing. And we kind of have a one-size-fits-all approach to antibiotic dosing, okay? Whether it's me or someone's not quite tiny. For kids, it's a bit different. But basically with adults, whatever your size or shape, we give you the same dose of antibiotics. Doesn't make sense, does it? Okay, there's some simple pharmacokinetics which will allow you to plan and adjust the dose right so we get the right dose into you. So this chap, he goes off, he writes a nice little application, it predicts the dose that you need to get the dose that you want. And then, so inzet in Dutch, I'm reliably told, I hope it doesn't mean something really dodgy, could do from Amsterdam. It means work or hours, okay? So this is the number of hours it took him to pay people in the hospital to get this implemented so that they could actually do a little clinical trial to evaluate it, not even to put it into production, just to study this process, okay? This is killing innovation. Oh, I went together, there was one other on this, isn't it? Yeah, this is the same, okay? Hospital that went to EPIC, they spent, just you see just down here, $220,000 just to try and code up one diagnosis across the hospital record, okay, because the data is messy. So we've had a couple of goes at trying to fix this, okay? The first go was something which we call Critical Care Health Informatics Collaborative. So wind yourself back to 2014, Dame Sally Davies reaches down the back of the sofa. She comes up with some cash. It's March the 31st. George Osborne is going to take the money back from her if she doesn't spend it. So she says, I hear this big data thing is good and important. Please go and do something good with routinely collected clinical data. They set aside, or they asked the 5 biomedical research centres in the country at the time, so Oxford, Cambridge, us, Imperial, and Guy's, King's and Tommy's, to basically go forth and do good things with clinical data. We're each given a clinical theme to look after. We got critical care, acute coronary syndromes went to Imperial, and our one job was basically to pull together those data, to try to overcome some of those barriers I've just shown you, into one database that we could then make available to researchers to try and do things with. This is where we were. The numbers haven't been updated, apologies for that, but it's about double, that sort of thing. We basically pull in data from those hospitals across those critical care units, and since 2014, and we ended up with a reasonably meaty data set. Where do we do that and how do we do that? Well, we were given an XML schema we were supposed to fill in. Not particularly well written one, I have to say. We move the data, identifiable data this is, so we've got patient identifiers in this, over to the UCL data safe haven. And then we spent a long time trying to fix that and make that work. And again, this is sort of, will this play with another button? Yeah, so I sort of show this because I think when you're trying to want to create an environment where people are going to work well, is that you have to make an environment that works seamlessly sort of for them, and it doesn't create more and more barriers. So this is sort of the log on process. It's all nice and secure. I speed the video up because you're going to get bored and so on. And this was about 2015, okay? So this was 2 or 3 years into the project. This is when I joined, okay? And after 4 and a bit minutes and so on of, you know, sitting patiently in front of my keyboard and typing into the terminal, I managed to find one temperature from one patient to the next XML file, okay? We're inside the UCL Data Safe Haven. We've got this amazing resource in front of us, but what we don't have is we don't have tools, okay? And in a walled garden, in a Data Safe Haven, building tools and doing the things that I think this room will understand incredibly well, that's collaborative software development, is almost impossible. We made some progress. We built a sort of a little R library, really to help us sort of tidy up that data and turn it back to you in decent format. It's been through a couple of iterations. And this is kind of the model that we adopted at that sort of stage, okay? So we move the data out, it's in secure storage. We have this R library, which basically allows you to take the data, prepare it and work with it in a region agile way. We have to just manually copy the R libraries we develop it in and out. But the nice thing about this is we also built a de-identification tool, so we can then bring the data back out. What we do is we bring out a sort of a crippled, or we call it a playground data set, okay, which we can then safely share with collaborators and researchers. They can then, if you like, do their work in their own environments, which I think what most people want. So wherever they are in the country, whichever university they're at, they can essentially prepare those scripts, we push them back in, and because everything's all kept in sync, you're able to sort of generate your scientific reports. And the stuff that library encodes is kind of just the basic stuff that you have to get right. So these are admissions to our ICU. And, you know, without building these sorts of tools, you just get really stuck. So either all the critical care consultants at UCH go on a holiday for 3 months, which would be nice, but isn't actually true. Or actually what happens is it's the NHS, we're all a bit strained and we're unable to do our data submissions for 3 months in the middle of the year. You need, and again, there's a sort of an 80-20 principle here, is that a lot of the work that you do when you come to do research and healthcare research and these things is just cleaning, tidying, preparing and organizing data. And that's really what we try to focus on, building these sorts of things. So this is just a simple data validation tool to allow people to work with these things. This was the anonymization process that we went through to make sure that when we took data out, it was as clean as possible. But I think, again, there's a paradigm problem with this, if you like, first round approach from this, is that we're really sort of pulling these data out. And we could write, and we have now written, academic papers on these things, but I'm a practicing clinician, okay? Half of my time is working on the ward, looking after patients. And the frustration with this is for all of that work and so on, is we can't actually go into the hospital and use any of these things we built. We couldn't deploy the pharmacokinetic model. We can't think about risk prediction. We can't actually make those tools work. We can do it in the university, but we can't actually do it in the hospital. And so part 2 of this is, I think, what Tito sort of build the talk is really to just show you a very brief overview of our attempt at fixing that. And it really does come from that story I told you at the beginning, is I went to the Health Foundation. I said, I'd like to build a forecaster for the critical care so we can look at bed occupancy, we can plan our admissions, and we can get patients in at the right time and keep our doors open even for emergencies when things look difficult. And the Health Foundation genuinely said, look, nice idea, but NHS IT projects are just not sort of safe funding bets. Thankfully, I'm your man. And I came back, and it wasn't just that Tito left, but it actually turned out that was a very glib response to an interview question. It wasn't all going to be okay. It was, in fact, incredibly difficult. We got very lucky, basically, at that time, because we were able to show our HIC work to the hospital charity. Now, the hospital charity, again, this is recorded, so please, I should be nice. The hospital charity is run by 2 gentlemen who've had a formal career as investment bankers, okay? They're super smart, and what they've been doing is they've been reading the Pink newspaper, and they've read the big data stuff, and they've looked at healthcare, and they say, well, big data and healthcare, we should be doing something in that space, okay? So they saw the HIC work, and we said to them we wanted to do just one thing. We wanted to bring that analysis pipeline from the university back inside the hospital. We wanted to really be able to do those same sorts of things. And they very generously then funded us a decent amount of money to try and make that happen. And 2 years on, that's sort of what I've done with my grants time. I've not built my forecasting model yet. I spent 2 years trying to get this platform to work. And I guess this is going to be incredibly obvious because I'm the doctor, not the engineer, this is a collaborative effort. So I'm going to just name check a couple of people, which is Mark White, who has been sort of the architect of the design of this process, and he's the Deputy Director of Digital Services at UCH. And Mark I first met soon after Tito left, because by then I got my Health Foundation grant. I'd been down to PC World, I bought a nice big fancy computer, and I plonked it on a desk inside the hospital, and I went and found Mark and I said, can I please connect this and plug it in? And he says, oh, okay, maybe. And actually, this is before we got the charity money, and we worked out a way we were going to try and put these things together. When we got the charity money, the question changed. Okay, it became around this idea of not just for Steve's particular project, but could we do this generically? Can we basically put a data science platform inside the hospital for people to use in general? Okay, it's got to meet exactly the same sort of things, and these were kind of our responses to it. Okay, we've got to protect those operational systems. I'm not allowed to write select star from patients. We've got to think about patient privacy, and this is the paradigm I've sort of hinted about before, as we try to have this idea. So if you put your data science platform inside the hospital, you can stop worrying about data leaking, okay? Because that's what you're doing, is you bring your code to your data, you give the tools that people expect to the people who can come and work there, and if you like, we can invite the people from across the Euston Road to come into the hospital. They get just the things they're expected to working on, a standard terminal, a text editor, an ability to do git push pull, docker push pull, and the rest of it. We've thought hard, and we spent quite a long time, and we struggle, but this has been an important part of it, of trying to make sure that things are interoperable. And again, we've tried hard not to be sort of tied into a particular vendor, so as much of this as possible has been built through open source. This is kind of the big overview diagram, and I'll just take you through this very, very quickly. So really, it's just a layered thing, okay? So this is the bit I'm not allowed to touch, but obviously we usually need to touch it once to get the data out, okay? This is where we do most of our work. And then this is kind of like what I call my coffee shop, okay? Is that I'm not always going to be in the hospital. If I want to genuinely engage with researchers across the world, we need to be able to give them the ability to work with the same tools in their own environment, in their things. So the real difference obviously is here, we're never going to have any actual genuine data. It'll be synthetic or it'll be genuinely de-anonymized. How do we make this work? Very simply, we go back to a really old technology. It's probably worth just putting a little story into this bit to give you sort of the context. So when we were doing the procurement for EPIC, I went out to Duke University in North Carolina, and I met a chap called Ian Sanderson, who was another doctor who knew about computers. And in the 1980s, he'd gone off and done a computers master's. And quite clearly, the NHS was no way ready for someone like that at that time. And so he went out to the US and he got a job there. And he was the chief information officer for Duke. In 2007, so Duke, and so North and South Carolina is kind of a bit like sort of the opposite of the North-South divide, the wealthy North and the less wealthy South. He got headhunted by the universities in South Carolina to come and do some work for them because they were kind of jealous of the sort of, so Duke obviously has tobacco money, wealthy Duke University computing infrastructure. So he gets down there in 2008 and he says, and they say to him, go forth and make good some data for us. And what's 2008? It's the economic crash. Okay, so he shows up, but there ain't no money. Okay, but because there isn't any money and they still want to do this, they were actually open to doing things in a slightly different way. So what they really simply did is they took their integration engines, they took those streams of HR7 messages in every single hospital, and they agreed for him to dump them all into a big pot, okay? And he essentially just did one initial task where he built a master patient index off that pot, okay? So he's got all those data that comes in, that he comes across. Now, Duke, paying attention to all of this, look across this, and this gets a lot of press. It goes incredibly well. They've got this amazing thing. It's called the Carolinas Collective sort of data resource. Duke, looking down across the line now, go, oh, that looks pretty good. We'd like one of those. So they hire him back. I'm sure his salary is doing good things at this stage. Okay, and he arrives back in the Duke, which is where we met him sort of 2013, 2014, and tries to do the same thing. Okay, but now there's money back in the system. Okay, so what happens this time? Nobody will sign the data sharing agreement to actually answer the data. So in South Carolina, he can go down and he can say, what is the average age of the patients in the Carolina Collective? Okay, because you can see the data which tells you the age of the patient. In North Carolina, he can tell you how many patients are there. You can count the number of ages, but you can't actually see what the age is, okay? Every single one of those needs to go through an ethical review board to get the whole thing set in a data sharing agreements. So we stole his idea, okay? And we've done exactly the same thing, but inside one hospital, if you like. But with the ambition, because it's all meant to be sort of open source, is that in theory, you could plug this in elsewhere. So this is not an Epic dependent system. This is just uses standard HL7. And all we do is we put one single pipe where we take the HL7 flowing through our integration engine and we simply move it over into a message store. That's it. And we do the same next piece as well, is we then spend a lot of time, and actually most of this year has been around, it turns out it's quite hard, building that master patient index and making sure that's reliable and works well. We also obviously have got other data sources. So where the data is stored in the archive or the legacy data stores, we can obviously pull that through. And Epic also obviously has its own reporting warehouse, this Clarity Caboodle structure here. The nice thing about this, and we quite like, I hope it's a good boast, I think it's a good boast. So we took and we showed an early prototype of this to the chief exec last year, and we have this nice fancy slide deck to show him and kind of a patient story to try and say it's all around patient benefit. The only thing which he was super excited about, and I think this is because he was actually a pretty smart guy, is when I wrote print date time dot now, and then I showed him the timestamp of the last message that arrived in the system. Okay, and the two will be within a minute or two of each other. So what we have is we have a real-time data store, and if you're interested in trying to do things for patient benefit and running the hospital, then having access to operational data in near real time, I think is a huge advantage. I think I'm running out of time a little bit. Is that right, TJ? Yep. Okay. So I'll skip through this. So then this is sort of it. So the other bit of sort of technology we use is we basically have the same sort of approach, is that you have a sort of a Dockerized environment where you can basically bring your applications in. You can git push pull across both things. And inside here, again, we have a series of layered databases. We initially tried to use something called OMOP, okay, as our primary data store, but actually learned very quickly that it was just far too rigid to actually accept all things. So we have a much more flexible sort of star schema where we store everything as it comes through, easy to write into. And then we've got really, this is me back to sort of being a doctor. I can understand an OMOP database. So it's a very simple healthcare database. Table of patients, table of visits, table of drugs, table of investigations. Okay, I can look at it, I know what's going on. We prepare all that. These two run in real time. This one then runs through GDPR and opt-outs, and we can then share this for research purposes. That's where we are. And then this was just meant to be a little demo of the things that we're able to do with these things. So we simply took patients' postcodes as they're coming through. We then popped that through to an open source mapping system, worked out the route they were likely to take to come into the hospital, and then basically compressed a year's worth of that to sort of show you a day in the life of UCH and patients coming in and out. It's 11 in the morning, it's busy. What you'll have seen as sort of the day starts is people coming in for their elective surgery, then being discharged out, it gets quieter through the afternoon, another little burst in the afternoon, and then overnight you just sort of see a stream of small emergency admissions coming in.